All right, guys. So it's 6 o'clock. Thank you all for joining us today. This is a topic very close to my heart. South Asians and heart disease. Is this a new emergent pandemic? And it kind of sounds strange coming from an interventional cardiologist who is focused more on PCIs. And many of our panelists today are interventional cardiologists. But that is something changed when I moved to Pakistan about 6 to 8 months ago, and I decided after spending 18 years in the U.S., I moved back 6 months ago and I joined NICVD, which is a public hospital. There are no financial disclosures for this webinar, except that the IT support is provided by Farmivo. We share a lot of things among South Asians. We represent 1/4 of humanity. And we share our love for cricket or art and music, and also for carbohydrate-rich diets like biryani and curries. But we also share this with this magazine cover on ACC Cardiology magazine. Being a South Asian, now we are considered as high risk for coronary artery disease and heart disease. And there's South Asians typically, Dr. Birani will talk about this later, but South Asian, they develop coronary artery disease up to 10 years earlier than general population. And there's 40% higher chance of mortality from heart attack among South Asians than the average population. And there's one trend that we are seeing in terms of diabetes, hypertension, and even heart disease. It's moving more and more towards low to middle income countries, and that's where we lie here. So this is definitely a kind of pandemic, and it kind of opened my eyes when I moved back 8 months ago. I joined NICVD. It's based in Karachi, and Karachi has population about 20 to 30 million people. And this center also caters to the healthcare needs of the whole province of Sindh. It has about 10 centers or hospitals with 20-25 chest pain units. And then most of the care if you can look at the time from 1 o'clock and to 6 o'clock, in 6 hours, we got about 15 to 20 ST elevation MI. This does not happen anywhere in the world. I remember in the US, when you get 1 or 2 MIs or 3 MIs a day, it's considered a busy day. So on average, we get hit about 30 to 35 MIs. And then there's also this concept of chest pain unit. If anyone who lives in Mumbai or Dhaka, they know the traffic situation there. So not a lot of patients can promptly go to the hospital, present to the hospital. So there's this chest pain unit concept where at a lot of busy roads or intersections, there is this container which has a doctor, EKG, and defib, or if someone is coming with chest pain, they can be evaluated promptly. If they have ST elevation MI, they get heparin or Lovenox, and they are referred promptly to the main center where the primary PCIs are done. So on average, if you look at 2019 number, just in 1 year, they do about 16 to 17,000 primary PCIs, which is a huge number. That makes us one of the largest network of PCI. Nothing to be proud of, nothing to kind of thump our chest. I think it kind of prompted me more to think, why are we doing so many numbers of primary PCI? What's going on here? Even when I was living in the US, in certain cities, we used to see some South Asians, but I've never seen such a disease burden that I see here in Pakistan. And then I thought that, instead of just having speakers from Pakistan, we should invite, speakers from India and Bangladesh. Dr. Samir is here, Asha is here, and see whether they see the same disease pattern over there as well. Are South Asians living in the subcontinent are different than living in UK or US? So this was the whole idea behind doing this webinar. So I don't want to take too much time. This was the brief intro that I wanted to give. And without further ado, I'm going to invite our first speaker today. It's Dr. Salim Birani. He's a very good friend. He's our AT. So next speaker is Dr. Samir Bhupta. He is Group Cardiac Cath Lab Director at Metro Group of Hospital, New Delhi. And he was in the same boat a couple of years ago that I'm in now. He also trained in the US and recently, a couple of years ago, returned back to India. And we're just curious how his experience been so far. Samir.
Thank you, Sohail. Thank you for putting this entire thing together. I would kind of echo your sentiments as to, when you come back and you start seeing a lot of heart disease, your first question is, am I missing something? Is it just the population? And then you delve into it a little bit more and you try and figure out that there is something else, there's something that we really don't know and something that we're missing. And over the next few minutes, I'll talk about the heart disease epidemic in India, what I am seeing, what the data shows, and the path forward. So I don't have any disclosures relevant for this talk. And like most presentations, I'll start off with the case. This is just a usual case that Aisha can attest to, that Sohail can attest to. Somebody, a 37-year-old person, male, comes to the hospital with chest pain, say this for 3 to 4 hours. He has not had any history of similar pain in the past. His risk factors: he does not smoke, no diabetes, no real family history. Blood pressure says, I got it checked a couple of months back. It was high. I just took some local medicines and, I'm not on any good treatment. His cholesterol, his total cholesterol is 224. His LDL cholesterol is 140. His HDL is, it's 140. It's not that high for that we would start treatment. And his HDL cholesterol is 34 and his triglycerides is 243. This is a classic patient we would see in our hospital. And you can see over here, his right coronary artery is completely occluded. He has severe disease in the circ. And he has an ostial LAD lesion. So he has triple vessel disease at the age of 38. This is a normal day in the cath lab for us. This is absolutely normal. We see this every day. And every time we see it, we ask ourselves, why is there a coronary artery disease pandemic? So like Aisha had also said, I'll just talk a little bit about India, a little bit about the demographics. It is a country of 1.4 billion people. There are 28 states and 8 union territories. There is a literacy rate of 74%. Literacy by definition means you can read and write your name, you can read a sentence, not necessarily read a complete book. 82% of the men in India are literate and 65% of the women. There are about 8.15% are college graduates and 39% of India consider themselves vegetarian. This is important because I will talk about this later. About 65% of India lives in rural areas, which is down from 72% in 2000. So in 20 years, there has been a demographic shift of people moving to urban areas. This has also led to a higher per capita income. Our per capita income now is almost $2,000 compared to $443, which was, so it's almost increased 4 to 5 times in a span of 20 years. The average life expectancy is also increased. It's now 70 years compared to 78 in the US, 67 in Bangladesh, and 67 in Pakistan and 72 in Bangladesh. And if you look at this 25 to 27% of all deaths in India are because of cardiovascular diseases. Like Dr. Virmani had said earlier, that Indians do get coronary artery disease almost 10 years earlier than our Western counterparts. And in the Western population, 23% of cardiovascular deaths occur before the age of 70 years. In India, this number is 52%. And when you look at MI, 25% of MIs are in patients who are less than 40 years, and 50% of CAD deaths happen before 50 years of age. And the Pure study has also shown us that Indians and Southeast Asians have more severe disease and poorer outcomes. When you look at the burden of disease in India, this is data from multiple registries and multiple studies that has been pulled together. When you see the proportion of cardiovascular deaths, that number is somewhere around 25 to 26%. But when you start seeing the 8 standardized risks, you will see that the Indian numbers are much higher. India in general has a much higher 8 standardized cardiovascular mortality compared to the US or to the globe. And when you look at more affluent states like Mumbai, when you look at more affluent places like Mumbai or Kerala, that number is certainly even higher than the national average. When you look at the burden of cardiovascular disease, this is the 8 standardized death and disability rates. The death per 100,000 ischemic heart disease is 144 compared to the global average of 104. The same thing holds for coronary vascular, for CVAs, for cerebrovascular disease, rheumatic disease, hypertensive disease, cardiomyopathies. Atrial fibrillation, the data is not very strong, but that is comparatively lower. Once again, it could be because of lower diagnosis, not necessarily lower incidence. Aortic, the same thing goes for aortic aneurysms and other miscellaneous diseases. But overall, if you see, if you see a comprehensive overview, the cardiovascular death and disability per 1,000 is much higher in India compared to the global numbers. This has also been replicated in multiple registries. In the Kerala ACS registry, less than 50% of STEMIs and less than 30% of NSTEMIs underwent reperfusion. This number is now changing with more advent of cath labs and more insurances coming into the picture. But this is data from the Kerala ACS registry. And the CREATE registry showed that in about 21,000 people, higher proportion of STEMIs were there in India compared to the rest of the world. In the Clarify registry taught us that patients in India were younger than the rest of the world and had a higher prevalence of diabetes. And the Indian Heart Rhythm Society showed us that the mean onset for atrial fibrillation was also 10 years earlier than the Western counterparts. So it was not just CAD, but also atrial fibrillation is more, happens earlier than the other parts of the world. When you look at risk prevalence, there are about 8.7% of people in India are diabetics compared to 10.7% in the US. When you delve down into this a little bit further, you will realize that there is a higher, in terms of sheer number, because of the population of India, the actual number of diabetics is huge. And also India, as Dr. Virmani had said, because of the phenotype of Indians and the Southeast Asians, there is a higher incidence of insulin resistance. India has about 30 to 35% hypertensive. This is by the old definition. The definition changed after the sprint, and this number will probably also increase for hypertension as it did in the US, where almost 47% are now hypertensive. Tobacco use is very rampant, whether it is in smoking or in smokeless tobacco. 30% of India uses some form of tobacco. This is more so in the lower socioeconomic groups, but is also there in more urban areas. And as far as hyperlipidemia is concerned, this is all data from Indian registries. 25 to 30% of people in urban areas have some sort of hyperlipidemia compared to 15 to 20% in the rural areas. And when you look at this, 79% have some sort of lipid abnormality done on the lipid profiles. So what is the most common cause of death? Ischemic heart disease is certainly the #1 cause of death. And this number has increased by 40% in the last 10 years. Even stroke, the incidence of stroke has gone up dramatically by 30%, and so has diabetes. Diabetes incidence has increased by 55% in 10 years. This is data from the Global Burden of Diseases published in Lancet in 2016. Diarrhea, because of better the government focus and a lot of not-for-profits working very hard, the death from diarrheal diseases and neonatal disorders has gone down dramatically. What are the risk factors which are driving these death and disability? You can see malnutrition and air pollution has gone down, but hypertension, tobacco, high fasting plasma glucose, dietary risks, high body mass index are all increasing in the last 10 years. When you look at hyperlipidemia, this is data from a large hospital database, and you can see that that 79% of adults in India have some sort of cholesterol abnormality. Low HDL is one of the most common things, almost 72%. Increased triglycerides is present in 30%, and high LDL, like one of the previous panelists had also commented, it's not very high when you see them with ACS, but a high LDL is 11.8%. So decreased HDL plus high triglycerides leads to atherogenic dyslipidemia, which is very commonly seen in this. This is data from the NIC. CSI is the Cardiology Society of India, and they have a national interventional council. This is data from their presentation last year about the coronary intervention data for 2019. So approximately so not all hospitals participate in the registry, so you have to take this with a pinch of salt, but it kind of gives you an overlay of the land. So there were approximately 330,000 MIs in 2019, out of which 50% got thrombolysis and only 2.3% got primary PCI. When you look at the data for primary PCI, the number has slowly and steadily been increasing. There are almost 500,000 PCIs which are happening in 2019, leading to a CAGR of about 12.6%. When you look at data by age group, the numbers are also increasing every year. This was data in 2017, 2018, and 2019. And you can see that these numbers are slowly and steadily going up also. This is by gender. Like the previous speaker had said, about 70% of all PCIs happen in men and 30% are in women. And when you talk about insurances, most of the people who are paying are from some sort of government insurances, about 55%. But you can see over here that own pay, self-pay, or people who are paying out of pocket, that number has gone down significantly over the last 3 years, from 40% down to 30%. These are some of the indications for PCI. Primary PCI was about 18% of the entire pie, and post-MI angina, which could be facilitated PCI, or if somebody is unstable after PCI, this could be the post-MI. And then you have rescue PCI and cardiogenic shock. So almost 60% of people had an intervention somewhere related to the STEMI or an ACS presentation. In acute MI, the numbers of interventions for acute MI have gone up. This is once again because of more awareness, more opening of labs, better accessibility, better availability, and more affordability. The 4 A's in healthcare has led to better interventions in acute MI to almost 15%. This is the amount of stents that were used. There were almost 6.5 lakhs, almost 600,000 stents which were used. This number is also going up every year, which kind of, is in tandem with the number of PCI cases that are happening. Now, some other statistics in terms of cardiologists, there are about 5,500 cardiologists. They are members of CSI. Compared to the US, which has almost 22,000 cardiologists. The unofficial industry numbers are more than 6,000 to 7,000 cardiologists, because not everybody is a member of the organization. The official number is about 900 cath labs in the country of 1.4 billion, but unofficial industry numbers say it's more in the range of 1,500 to 2,000. As far as stent usage is concerned, that's about 50-50. There are MNC players, which are the FDA approved players, and then there are the other indigenous stent manufacturers in India. That number has gone up dramatically over the last few years. I'll talk a little bit about our hospital and what we see. We are a group of about 10 hospitals in North India. Our annual PCI volume is about close to 6,000 PCIs, and our flagship hospital, where I head the lab, is about 2,500 PCIs a year. We recently started a registry. We've made some attempts to start a registry and try and understand some of the patient demographics and our outcomes. So this is a first cut of what you're seeing. Hopefully by the end of the year, this registry would have gone to more hospitals, and we will get some more granular level data of risk factor profiles and treatments. So if you can see over here, majority of our patients were 60 to 69. This is 500 PCIs, close to 500 PCIs that we did in the hospital in a span of about 3 months. About majority of our patients were 60 to 69, but there was a significant percentage of patients, more than 10%, who were in the 20 to 40 age group. After that, and as you obviously age, the number of procedures went up and then. This is the just 1 second. The indication was STEMI for about 167 patients, which is 167 out of 500, almost 30% of patients had STEMI as a diagnosis. Out of which out of which 5, there were 51 times we did primary PCI. For the rest, it was delayed, facilitated, and they were not counted in this 51. But for these 51 patients, RCA was the most common culprit artery, and after that followed by LAD and OM. I think there is some bias over here, because patients who the RCA patient may have driven the extra distance to get his care compared to an LAD patient who was probably got his first cut at the local hospital. This is the risk factor profile for some of our patients. We had about 41% of all our patients were about were diabetics. There were 54% who had hypertension, and almost 30% had some sort of family history in the risk factor profile. Now, I know that significant family history is 55 and 65, but this is more for any family history that was noted in a first degree relative was noted, and the granular level details we will come to know as we analyze the data further. Now, what about dietary patterns? I said that almost 40% of India consider themselves vegetarian. Well, if you look at the National Family Health Survey, which was a self-reported survey of almost 150,000 patients, 150,000 individuals, 50% of them said they consume 0 or 1 serving of fruit in a week. And there was a social gradient in the consumption of fruit. The lower socioeconomic group had the lowest consumption. Also, when we cook food in India, there's a lot of overcooking which happens, which leads to a lot of loss of micronutrients and other antioxidants. And then between 1972 to 2000, this is the National Sample Survey Organization, what they found was that even though the net calorie intake had not changed that much, there was an increase in the intake of fat from 36 grams to 50 grams in individuals. There is also poor physical activity in India, and we can talk about that at a later date. But another very important thing we don't talk about enough is air pollution. Air pollution is very prevalent in most parts of India. I live in Delhi, it is the capital, and it has extremely toxic air levels at most points. The air quality index, which in other parts of the world may be 50, 60, in Delhi, it often runs to, more often than not, it runs to about 300, 400 with very high PM 2.5 particles. And air pollution is right over here, right next to cigarette smoking, is a very important thing, which I feel is contributing to the cause of the CAD pandemic in India. This is a lipid profile test of a patient. This is pretty interesting. As you can see, she's 11 years old. I treat her father for pulmonary hypertension. He has really bad COPD. So we run a pulmonary hypertension clinic. So her father came with me. Her father came for the appointment, and he just showed me a cholesterol report. He said, "This is my daughter's cholesterol." The daughter was sitting right there. She was 11 years, maybe a little bit on the heavier side, but not, I wouldn't call her obese. But she was a little bit heavy. And he said, "I got this thing done. What are your thoughts? Should she be on medicine?" And as you can see, this is just a month, 2 months ago. And her total cholesterol was 200. Her LDL cholesterol was 120, and her non-HDL cholesterol was 143. It left me speechless, and I asked him. I said, this person is morbidly obese. Does she eat chocolates? Does she eat pastries? Does she eat cookies? He's like, "Yes, she does that often." I said, "Have you ever thought of putting her on a diet? Her cholesterol is high." And his answer was, "If she doesn't eat now, when will she eat?" So this is kind of just really this thought really struck with me as to the mentality of the people towards food and their ignorance towards healthcare, even though there's somebody in their house who might be suffering from an illness. Suhail asked me to talk about some policies. So the government has started the National Health Mission. This was the National Program for Prevention and Control of Cancer, Diabetes, and Cardiovascular Disease and Stroke. And this was started in 2010. And this kind of clubs all the non-communicable diseases in that. And via this mission, they're trying to improve the awareness and primary treatment for heart disease and non-communicable diseases. And I saw there's a 2015 update that they've diagnosed 90,000 people who have cardiovascular diseases. And they've diagnosed 8% of the people who've come up there were diagnosed with diabetes and 12% with hypertension. The way healthcare works in India is a little bit different than the way it works in other parts of the world, especially the US, in the Western world. Over here, we have a very robust private setups, and blood tests can easily be done at home. And most people, especially in urban areas, not necessarily in rural areas, they avail of one of these packages. It is expensive, but not prohibitively expensive. And they get themselves tested at home, and then they usually send these reports to their treating doctor or to the family doctor for a first look. There are also a lot of screening camps that happen at offices with that tie-ups with corporates, with the Residents Welfare Association. There are multiple health checkup camps that are done in most cities around the country, where they try and screen patients for hypertension, diabetes. They can have something for liver disease. They can have cancer screening camps, etc. Regular health checkups are also done, and they're sponsored by the employers for their employees in most corporates and in some private organizations also. And most hospitals, most private hospitals around the country have health checkups where you can go and get an echo, ECG, and a treadmill test after a quick consultation with a physician. Most healthcare facilities, big healthcare facilities, are also doing a lot of outreach in tier 2, tier 3 cities to get specialized healthcare that may not be available in those cities to those patients who are living in these cities. And after COVID, digital healthcare has certainly has accelerated the shift and really changed a lot in terms of accessibility of healthcare. Now, there's been a complete, there are a lot of private apps, and using these apps, people in tier 2 and tier 3 cities can easily get a consultation with a cardiologist, oncologist, or any specialist in sitting in a metro city. The way forward in India is India has done a very ambitious project of the PNJ scheme, which is going to provide healthcare, which is in the process of providing healthcare to most low socioeconomic status patients. And and a lot of big corporates and private hospitals are also now getting empaneled. So if anybody needs healthcare, if anybody needs basic PCI, for example, they can go to a PCI empaneled hospital in their area and get the required treatment, and the bill is going to be given by the government. So this is a very ambitious scheme. We are working very hard to make it successful, and we hope that this will really change the scope of healthcare in India. So, whenever we look at healthcare, when you look at healthcare across the world, or especially if I have to say about India, there are the 4 A's, right? The first is availability. Is this available or not? Whether that's in your country, whether that's in your county, wherever that is. And then comes the question of accessibility of healthcare. And the same thing goes, and all these things can be easily extrapolated to coronary artery disease or for heart disease for that matter. Then comes the question of affordability. And then in the end, you start talking about accountability or quality. So we are probably somewhere in the range of accessibility and affordability. And after these things are a little bit set, I think there'll be a big emphasis on accountability and quality by creating national registries for PCI and other diseases. I think there's a big interplay of social and biological factors in India that increase the incidence of heart disease in India, but also in Southeast Asia in general. More research is needed to better understand the biological factors. I know Dr. Vermani had said we know a lot, but there's a lot more we don't know. And I think there's a lot more we don't know. And I think this will be very important as we go forward, because primary prevention remains the key. And the various schemes and policies are being developed to improve all the A's of cardiovascular care in India. Thank you so much.
All right, thank you so much, Samir. We have 2 more talks, so it's good to get an Indian perspective as well. It was a thorough review of that. And there's one thing that I hear people say sometimes on like Twitter that, I saw one patient a year ago whose calcium score was 0, but that patient had MI. But what we should look at the bigger picture, right? Especially in the countries like Pakistan, India, Bangladesh, and because of the low socioeconomic status, I think calcium scoring has a great role to play in terms of cardiovascular disease prevention. So this will lead to the last talk of the day. It is on prevention versus intervention, a dilemma for Pakistan future strategies. And the speaker is a very good friend, Dr. Bashir Hanifa, who returned to Pakistan about 15 to 20 years ago. And he's been instrumental. He's been one of the trailblazers in cardiology in Pakistan. So without further ado, Bashir.
Thank you very much, Well. It's a pleasure to be here with especially among the giants in prevention and cardiology. I think most of the things has been talked about, because a lot of obviously problems as well as the solutions we share with, I would say, India or Bangladesh. And a lot of things has been covered about that. So I will try to skip those things and focus on few things which hasn't been particularly related to Pakistan. So I think I'm not going to talk about overall CVD burden. So briefly talk about current status of preventive versus interventional programs in Pakistan, challenges we are facing in terms of prevention of cardiovascular disease, what are the barriers to implement those any kind of preventive services, and what is the way forward or future prevention. I would like to thank Dr. Howard also. I did borrow a few slides from him. Again, I think we know it's number one killer, but one of the actually alarming fact for me, this is from British Heart Foundation, that someone has a heart attack every 2 minutes, which is really alarming for all of us. We know that the leading cause in South Asia, as well as dialysis and death from cardiovascular disease, is number one. In terms of, if you look at South Asian countries, and if you look at Pakistan, basically 2/3 of the deaths, as well as dialysis in South Asia, Pakistan shares more or less similar as compared to other South Asian countries. It's just probably a little bit lower than Sri Lanka and Maldives, but rest of them more or less the same, Bangladesh as well as India. Institute of Health Metrics and Evaluation actually has predicted that by 2030, cardiovascular disease will account for a higher proportion of deaths in low and middle income countries than in the high income countries. And if you look at South Asia, these are females and males, and the number is significantly high as compared to the rest of the world. Again, if we look at the health profiles of South Asian countries, and these are different, Afghanistan, Bangladesh, and others. And if you look at health financing, unfortunately, Pakistan remains almost, even in South Asian countries, at the lowest side. Overall total expenditure on health is 2.9%, which is lowest as compared to any other, even South Asian countries. General government expenditure is also on the lower side, and per capita total expenditure on health is also the lowest, and that is probably one of the major problems. Even in South Asian countries, Pakistan unfortunately goes down. And if we look at other factors among South Asian countries, this is the NCD capacity profile, and a lot of these things are, if you look again in Pakistan, it's basically, you see all of them are no. We don't have a risk factor survey, we don't have morbidity survey, service utilization. So a lot of these things which are required to really deal with these NCDs, unfortunately, are not there in Pakistan. We know there is a decline in the death rates from cardiovascular disease in Western countries significantly over last decade, while in South Asian countries, including Pakistan, these numbers are increasing, and this is the epidemiologic transition which Dr. Aisha mentioned as well. Now, we also have some data from Inter-Heart study on South Asia as well as in general. 9 simple risk factors were responsible for almost 90% of the risk of AMI. And if we talk about South Asian countries, we know that it comes at a much younger age, the acute MI, and if we focus on those risk factors, we may be able to prevent those acute MIs. We know in the past it was a dual burden of communicable and non-communicable diseases, while now with the epidemiologic transition, non-communicable diseases are surpassing. Almost 2/3 of the total disease burden in Pakistan is from non-card NCDs. And again, the numbers may not be exact. There are some estimates in it. Around 12 people die of heart attack every hour. And I'll show you the recent the PROB data, which is the cardiac registry of Pakistan. The average age of first MI was around 55, 56 years, and there was 6 years younger, with a higher number of risk factors in the younger population. And unfortunately, I think just like other South Asian countries, there is a poverty trap. Anyone who gets a heart disease, this is going to make things worse. People have to sell their houses, and then they keep getting worse and worse because it's a lifelong disease, and the overall health conditions continue to worsen, resulting in this trap. Ischemic heart disease remains number 1 cause of death. Life expectancy, looking at Dr. Aisha just mentioned earlier, it's actually even less than Bangladesh. According to these WHO numbers, it's like 65.7 years. Again, cardiovascular disease is number 1. And overall deaths around 20.28%, and Pakistan ranks in the world around 18th in terms of total number of deaths from coronary artery disease. No, this was the first paper we actually had an abstract presented at American College of Cardiology from our cardiac registry of Pakistan, which I'll briefly tell you later on. We were actually lucky to have this, and this registry, as Dr. Samir mentioned as well, they are trying to do these registries in India as well, and this really helps a lot to find out overall disease burden and what can be done about it. And we were able to start this cardiac registry of Pakistan, and this was mandated by Supreme Court of Pakistan that every cath lab has to be part of it. And we looked at the risk profile and outcome of patients with premature and extremely premature coronary artery disease compared with older adults. Now, premature, we label less than 65 in females and less than 55 in males, and extremely premature, less than 40. And looking at that, we actually looked at almost 15,000 patients, and out of that, around 6,000 were older and 9,065 premature, and almost 1,118 extremely premature. And as Dr. Aisha mentioned earlier, our numbers for premature and extremely premature for females were actually around 30%, as compared to what she mentioned, they were lower. But surprisingly, in older age group, which is like more than 65 years old, the females were only around 10%. So I think, again, the reason which was discussed is more likely they won't present to the hospitals as compared to not having the disease. Disease is almost there. So what we were able to actually conclude in this, that frequency of traditional risk factors, especially tobacco smoking and obesity, were particularly high. And again, the risk factors in the premature and extremely premature were much higher as compared to the older adults. Sorry, 1 second. So I think there's a significant economic impact or burden. In 2005, it was estimated again around $1 billion of national income from premature deaths due to heart disease and stroke and diabetes. And this estimate is going to increase to $31 billion in next 10 years or so. We know that there is a mismatch or a 90-10 disequilibrium between established market economies and all others, that overall the expenditure is 90% on overall Delhi's and is like 10%, while in low income countries or middle income countries or developing countries, it's the other way around, that Delhi's are much higher, like 90%, and the health expenditure is much lower, as I showed in earlier slide also. There's a care gap also. It has been actually shown in a pure study that low to middle income countries are really unable to, due to socio-economic problems, unable to really take these drugs which are necessary for secondary prevention. And even if you look at overall in high income countries, the number of drugs were much higher as compared to in the low to middle income countries. So Pakistan socio-economic, I think this problem is true, same for India as well as Bangladesh. We do see from one extreme to other extreme, these are present in Pakistan and other low to middle income countries also. And similarly, there's a health polarization also. Those who are able to afford, they can go to these private institutions, while others has to go to these government institutions where facilities and services are not that great. I think all of you have heard about this thing that someone was trying to save someone who was being drowning in the stream, and without realizing that who is pushing that person down into the stream, and he kept trying to save them. I think if you keep trying to save it without realizing the cause, it's going to be very, very difficult. So I think our most of the time response is anyone we see, we start applying CPR without realizing we need to establish the cause and find out what's going on. We start working on mostly like creating new state-of-the-art tertiary cardiac care centers. Even in Pakistan, every city, there are new hospitals and tertiary cardiac care or even tertiary general centers are being made, but no significant preventive cardiology service or setup is there. Again, top line procedures, everyone is really very proud to tell that we are doing the best procedures or most difficult procedures without looking into the cost and benefit. Primary PCI definitely has a role, and as Suhail mentioned, they are doing a lot at Cardiovascular Institute in Pakistan in Karachi. But again, I think it is very important to keep an eye and look at status of secondary prevention and primary prevention. Now, if I give you some numbers of prevention versus intervention in Pakistan, currently there are around 130 to 135 cath labs all over Pakistan. And the registered or certified interventional cardiologists is around 475 to 500. Versus preventive cardiology programs or institutes or departments are in the institutions is maybe only 3 to 4. Dr. Howard Kazmi may have one, we have one, and maybe 1 or 2 other institutes have those preventive cardiology setups, but those are also in a very primitive stage and not really up to the mark. And if we ask, are there any preventive cardiologists? And the answer is going to be really none. We can see even in this symposium, most of us are sitting there are mostly interventional cardiologists as well. There are a lot of reasons behind it. Obviously, financial is one. There are no proper training programs for preventive cardiology and no real incentives. I can tell you in our program, we recently advertised for an interventional cardiology fellowship. For one position, there were almost like 50 candidates. And I've been trying to have a preventive cardiologist in my program for last like 2-3 years. No one is willing to become a preventive cardiologist. This is unfortunate, but that's the reality of the fact. Health structure and system in Pakistan, mostly it's private sector. 70% of the patients get their services from the private setup, and that is fee for service. Healthcare services by, again, armed forces, hospitals, NGOs, and social security institutions, they facilitate their own providers. There is no real mechanism to monitor their clinical practice or quality of services. And obviously, there is a non-existent focus on preventive healthcare services. Unfortunately, that is true among all across the institutions in Pakistan, and I think probably true in other countries, these developing countries as well. There are poor health indicators. We all know very well. We all talk about it. We know, all of us, that prevention is the key. There are different ways to prevent. We talk about it, but unfortunately, the focus of the government as well as the institutions and society is not as much as it should be. We know that risk factors starts in the childhood. We focus on maybe adults, but we forget the childhood and youth. Worldwide, there are 22 million children under 5 years who are obese or overweight, and they are at a significantly high risk. Again, similarly, the smoking is becoming very prevalent in young children or youth, and that is again a major problem. Hypertension, type 2 diabetes mellitus, these are also becoming high. This is one of the studies, I think Dr. Howard was part of it, Habit, in which they looked at the school children and found there were significant number of children who had increased waist or BMI was significantly on the higher side. Government, again, autonomous and private health institutions has to play their role, but unfortunately there are lack of resources, misdirected priorities, lack of political will, and that's one of the major problems. In terms of the risk factors, one of the recent studies did show that around 40% of the Pakistanis were hypertensive, another 20% were using tobacco, another 20% are high cholesterol, and around 20% of the population was obese, and around 11% pre-diabetes and 17% diabetics, which is very high number. And similar are the numbers with dyslipidemia as well. There is significant potential for prevention just by controlling risk factors. We saw in Interheart study also 90% of the acute MIs can be prevented if we look at all these modifiable risk factors which are present. We know this is really becoming alarming. Tobacco control legislations are available all over the world. We can learn from them. We can have it. Unfortunately, it's not happening. In Pakistan, I just found out that the lowest tax in the world on cigarette is in Pakistan. So it's so easy and so cheaper to buy as compared to other countries. So really need to work on that. Overweight and obesity, even it used to be considered the disease of the developed countries, but now it is in the developing countries also. Physical activity, unfortunately, is lacking in schools or even later on, especially in urban areas. It's becoming very, very difficult. No guidelines. Again, we have seen, this is one of the pictures from one of the cardiology meetings, and you can see no one is going on the stairs and everyone is, and this is true with us also. We do the same thing, and unfortunately that's causing a problem. Dietary guidelines are lacking. Again, we really need to focus. There are several, we know there are examples of community-wide cardiovascular prevention programs that has a significant impact, and we can learn from them and try to implement in our country. There are several constraints for having these prevention programs, but again, there is a will, there is a will, there is a way. We can find out the ways to really put those into place. Limited recognition and available data on CBD. There's no commitment, unfortunately. Prevention is not taken seriously because of the market pressures which are favoring the interventions. Again, healthcare needs not addressed. Costs are rising and resources are really decreasing day by day. Everyone has to play their role, but unfortunately, government, there is very bureaucratic, slow and ineffective, failure to influence. And I think, I'm sure all these words must be familiar to my other friends from India, Bangladesh, or other developing countries. The same problems are in those countries as well. Medical education systems, again, is not geared towards prevention. That is also geared towards therapy and treatment. And we need to really focus on that. And we need to incorporate these prevention in our education curriculum, whether it is undergraduate or postgraduate. We need to have public health institutions where we can train these people, and those healthcare systems, preventive systems, can really help to improve all those things. There are significant barriers. We can overcome those barriers. And I think one of the things which I wanted to talk, and Khurram also mentioned, I think first time in Pakistan, we are launching with this study by the name of Pak Sehat. This is going to be all across Pakistan in younger people, less than young, like 35 to 45 males and 45 to 55 females. We will have at baseline, basically all their evaluations and anthropometric measurements, as well as history, physical, and all their risk factor profile. And then we will have actually baseline labs. In addition to that, I think two other things which we are going to do, which Dr. Khurram also mentioned. One is that we are not only going to do a calcium score, but we'll be doing a CT angio on these patients to really characterize the plaque. And on top of that, we are also going to have a carotid ultrasound to look at intima media thickness. And the primary objective is to characterize the prevalence and severity of subclinical coronary atherosclerosis among young Pakistani men and women free of clinically symptomatic ASCVD. And also, as we have discussed again and again, that the risk factors or the risk scores which we use may not be applicable to South Asians. And this study will also help us to really calculate the risk scores. And we are going to follow these patients over 5 to 10 years and look at other secondary endpoints as well. This will be a landmark study and hopefully will help us to look at a lot of things and hopefully answer a lot of questions and help in terms of decreasing the burden of the disease. Again, I'm not going to go into the details, but again, there are several preventive strategies, primary, secondary. One of the most other important thing is, unfortunately, I think it's probably more problem related to Pakistan, is that strengthening of research capacity. That is very lacking in Pakistan. Basic knowledge of epidemiology, biostats, and public health should be core components of postgraduate education, and CME training programs should be a must for doctors. And that will help us to build the capacity for research, and that will help us to actually improve the surveillance system and have a data to base our planning on that. And that's why we are now having this, as I mentioned, Cardiac Registry of Pakistan, CAT PCI. We are also launching a heart failure registry and EP and device registry. So these registries and the research for the primary prevention will help us to improve on things. There are more than 50 medical universities and colleges. Only few institutes have accredited public health research training programs, no school of public health, and minimal training. Few medical journals are indexed. So publications are also limited in international journals. So we are lacking behind, and we really need to work on those things. I think I just a couple of more slides, and already time is over. I won't go into that much detail. But key components of CVD prevention, according to NICE guidelines, is we need to tax on tobacco products and ban on public smoking. Again, there are a lot of active groups who are working on it in Pakistan, but unfortunately, things hasn't happened. And as I said, this is the lowest tax currently, and we need to get together and try to convince our government to look into that. Reduction of salt, saturated and trans fats, and food labeling is very important, which is not there. We need to change our agricultural policy, physical activity, health monitoring, and all these things really, actually, for the future of CVD in Pakistan, we need vision, commitment, and dedication from cardiovascular community and leaders and professional societies who really can do it if we work together. And as these 4 A's, I think Dr. Samir which mentioned, we are probably at the same crossroads. We have access and we have affordability, but again, the quality and monitoring and all those things are not there. I think the few things which has really happened well and is going to go a long way for Pakistan for in terms of access and affordability. Pakistan government has launched what we call as a Sehat card, with which every person can go to any hospital they want and they can get a procedure. Obviously, there is certain limitation, but this has really revolutionized the treatment and therapy. But unfortunately, again, the prevention is not covered under this card. Similarly, Cardiac Registry of Pakistan, that is mandated by Supreme Court for every cath lab. This will help us to have the data and basically plan for the Pakistan in terms of overall cardiovascular disease. Recently, Khan has received significant research grants for training the personnel and the resources in research. That will also help us to improve in terms of conducting research. And Pak Sehat study, which I just mentioned, has really helped a lot. I think I won't be going into those details. Just last slide. Here again, as I mentioned, every one of us has to play a role, the government, cardiology institutes and universities, private sector, and we need to focus all of us on NCD prevention. Problems are there, hindrances and challenges are there, lack of awareness, lack of resources, lack of political will. But as I said, if we really work together and all these get together, we can make a difference and we'll be able to do something. And we need to have full-time public health experts, our cardiologists, education and training of all these family physicians, faculty and fellows, and children and youth and public, and everyone need to be trained and educated about primary prevention. And the way forward is really there. Eliminating major risk factors for non-communicable diseases can prevent almost 80% of the heart disease, stroke, and type 2 diabetes. Enemy is there in front of us. We do not need drone attacks. We need to take it on up front. So Sehat card is an excellent initiative, and unfortunately, as I said, no preventive package. We know a lot what needs to be done, but unfortunately, we just does not get it done. And but as I said earlier too, we can definitely change it by working together and working in collaboration. I think we can achieve. Where there's a will, there's a way, and we can definitely do that. With that, I would end. Thank you very much. I'm sorry if I took a little longer time.
Yeah, thank you so much, Bashir. It was a great talk. So we have gone over time, 90 minutes. So what I'm going to do, I'm going to give another 20 minutes for Q&A and discussion. And I'm going to open the forum for discussion. I'll be joined by all the panelists, plus Dr. Khawar Kazmi, who's the head of preventive cardiology at NICVD, as well as Viet Lee, who's a very good friend from Salt Lake City, who's always passionate about preventive cardiology.
Well, maybe I can take a lead here.
Sure. Yeah.
Okay. Well, when I look at you, I mean, it's kind of I have mentioned already, it's kind of a deja vu. When I came back in early 90s after my intervention cardiology training and started doing PCIs, I exactly had the same feeling as you had mentioned and our colleagues from Bangladesh and India. And that's what changed my heart. So, and I think maybe I can make a correction to Bashir's rendition that maybe I'm one of the preventive cardiologists who is dedicated to prevention, because I stopped doing intervention and focused my whole thing on prevention. That was the time, I mean, mid 90s, that Salim Yusuf approached us at AKU and we joined Interheart, and so India was part of that. Srinath Reddy and Prem Pais, and from Bangladesh also. Actually, Aisha, I mean, when the Diabetic Association was starting the cardiology hospital, the two cardiologists who initially started intervention there had a brief exposure at AKU with us to start the intervention there. So, I mean, so what was mentioned in that, I mean, my worry here is that in 30 years, I've been talking about exactly the same thing as we are talking today. The numbers have become worse. The actions have not changed. Interheart, Salim mentioned Interheart, and Salim, he also mentioned the positive side of the positive message of Interheart from Interheart South Asia. Yes, it is a positive message, but it will only be positive if we would do something about it. We have not done anything about it. We're still talking about the same thing. We need to do more research. We need to know more about this disease in South Asians. But I think we need to also act on what we already know. We know about the lifestyle. We know from Interheart about the lack of use of fruits and vegetables, the physical activity, which is so disparately low in South Asian countries, both India, Bangladesh, Pakistan, all of us. We are all on the same board. But unfortunately, I think we all, I mean, as Bashir has mentioned about the things which we are, I mean, we are doing CPR at the time. So this is my worry, and I really would want to see that we are not doing the same thing 20 years later. We do something which makes a difference here. If we don't make a difference, the boat is going to sink. I think so. That's one of the important messages which I'm going to say. Khurram, I think from your talk, I mean,
I just one comment. I just wanted, I think so. You've raised a great point, and it made me wondering, you know, if we are producing crops that or food that nobody is eating, shouldn't we be now trying to grow different crops? I think so. That's really what it is. It seems like this whole redundant approach in preventive cardiology, as you know, it's a newer field. Even in US, it really came into being in the 90s, which really grew from lipidologists. Really, that's what the preventive cardiology was. And I think so, you know, it just seems that the public's not attuned to this whole concept of treat everyone. And you're rightly bemoaning that it hasn't gone traction because there is no model. But I think so that's what we need to work in. Do we need to create the Amtrak? Or do we need to jump to the bullet train? Because that's kind of the whole thing is if you look at in China, they're doing the bullet trains, nobody's making the Amtrak. So I think South Asia has an opportunity to leapfrog and learn from the mistakes of the preventive cardiology programs over the last 20 years in US and do not make the same mistakes. So I think so that's kind of what we need to do is think what is going to be applicable.
Yeah, I agree. I agree. But I think we need to have more innovative approach of, I mean, making this in a limelight. But I think just one point, I mean, I was going to take from your, I mean, I understand the need for, I mean, the role of calcium score. And you mentioned, I mean, it's cheap in Pakistan, 3,000 rupees. 3,000 rupees is about 10% of the average monthly income of about 40% of Pakistan's population. And so if they get a CT calcium score done in 3,000 rupees, they may have to starve a couple of their children in house for a couple of days. So although, I mean, I think it's cheap from US standard, but I think we'll have to really look at that from that point of view. And I mean, I think your point again, I think we need to have more attractive approach, which is I mean, I think which can change, I mean, people's approach. And similarly, I think which is more kind of implementable at a larger scale in countries like Pakistan.
Agree. So I agree. I just want to add on this because this was a question directed here. So let me chime in first. So you're absolutely right. 3,000 rupees is pretty high, but you know, the statin cost is almost 7,500. So the same pair as an health economist, I'm just thinking out loud that as a health economist, if let's say it's the Sindh government in your case, or maybe the Punjab government, or even the family or any foundation who's willing to pay 70,000 rupees of medication for 10 years, I think so it may be worthwhile scanning 3 people for 10,000 rupees to identify one who may not need it. Now, again, we have to figure it out. But the other issue is I've spoken with family members, friends, even colleagues and other, and say, are you really asking me to go on a statin for the next 10 years and 15 years? Why do I need it? So, we are facing with diversing realities, and we are coming back with the same solutions, trying to convince more people that I can't even convince in US. And we are having bigger trouble in the South Asian. And that's what I think is the definition of insanity, is trying the same old things and asking for different results. So we need to be more creative. I'm not saying that we should be just doing calcium, but these are kind of the innovative approaches that will help us for resource allocation. And the government of Pakistan and the provincial governments need to play a big role there.
I agree. I think even for statin point of view, I mean, Bashir, I think, showed a slide from Pure. And so Pure, again, I think is India is part of Pure, Pakistan is too, so is Bangladesh. I mean, so in Pure study, again, Salim Yusuf leading that, almost the use of 4 secondary prevention strategies, which are aspirin and a beta blocker and a similar and statin, the use is less than 1%. It is in those people who already had an MI or stroke. So, I mean, statin is also, I mean, not something, I mean, we're talking about primary prevention. I mean, here, I mean, not is being used in secondary prevention. So we need to have a very different approach, and government is not into prevention at this time. As Bashir had said, I mean, we have a Sehat card, which covers a cost of ₹1 million for a year for a family, but it does not, it would cover the cost of stroke or a PCI. It would not cover the cost of use of hypertension medication. So, I mean, they will not prevent a stroke, but they will treat a stroke.
Yeah, I think, I mean, Dr. Kazmi, I think we are too stuck on just the statin therapy. I think, look, there are some things that the countries like US and UK have done well that we can learn from as well. And I think what they decided in 80s was that we're going to have 2 sides of approach, right? One is the high risk strategy, and one is the community level, the population based strategy. I think what Aisha presented, what Samir presented, what Dr. Bashir presented, I think that high risk strategy has to stay. Those highest of the high risk need to be taken care of, need to be on guideline directed medical therapy. And that's what has led to 50% reduction in mortality in US. The other 50% is related to better risk factor control, which again, we've had a slight increase in obesity and diabetes again. But in the last 50 years, that's where I think a lot of work has been. And I do believe what Dr. Bashir was saying. I think we do have an opportunity to go back to some of these schools and do some, I think if you look at the South Asian countries, social media is even more powerful than some of the other regions actually. So leveraging that, how do we get people to even have these minute differences whereby even 2 millimeters of mercury blood pressure reduction at that level can lead to very large reductions 20 years down the line. I think it's not just about statin therapy. Yes, that we can talk about, but I do believe that there is a lot of work that needs to go in these other risk factor control as well. And even in young people, we don't even know what's the FH prevalence in Pakistan. I mean, that's like an easily treatable disease. There's not too many questions that are being asked. So I think we need to look at both of those. And what I worry is that we try to study the disease a lot. So we get into this analysis paralysis mode. And then we just study, blood tests, lipid tests, imaging studies. I think we need to have a parallel arm where actually there are people who are just dedicating their life to interventions and learning from that as to how they are scalable and what is the best strategy for various parts of South Asia. So I think both of those need to happen in tandem.
So just trying to piggyback on what you said, doing something on a population level, and also what Bashir said in his talk, that there need to be more collaboration among the institutes in Pakistan. So there's one thing that I talked to you a couple of days ago, and I talked with Howard Kazmi before the webinar. We are in the process of designing a study where we are actually looking at lipoprotein A levels in South Asia. And again, most of the study, when we did the literature search, was done in UK. South Asia is living in UK and USA. But there's something that, again, we are seeing more prevalence of that disease here in Pakistan and India. So we need some more local data on it, even in those patients who have normal LDL. So that could explain why we have such a high disease pattern. So I've also talked to Dr. Aisha Kader about this study that we can do an arm over there, and Samir Bhupta as well. And we will definitely talk to Dr. Bashir Anif as well if you want to come on board. I mean, that will add so much to the question of lipoprotein A. And I'm getting so many questions here on the chat box. We should definitely do another webinar just on lipoprotein A sometime.
Yeah, can I quickly say something as well? We have included actually lipoprotein A in our PAK-SAGE study, and those 2,000 patients from all over Pakistan. Actually, we are going to collect the data on 4,000 patients, but CTA will be done on 2,000 patients. So we will have LP(a) on 4,000 patients all across Pakistan as well. So that will help us to do that. My question to Salim was, ApoB, which you are mentioning, we were actually discussing, and we will have the steering committee meeting and discuss that. Do you think that should be considered also? I don't even know if it is done in Pakistan or not.
ApoB is available. It's even more easier, easy test to get done than lipoprotein (a). So I am almost certain it can be done. And ApoB assays, again, there's a little bit more standardization that's needed, but it's there and it can be done. And I do believe that in Pakistani or Indian or Bangladeshi context, South Asian context, you will find that that is an issue, that discordance that people talk about, and then for very good reasons, because of high triglycerides and insulin resistance. So it can be done.
Thanks.
Just clarification there. I think ApoB was the one which was used in Interheart. ApoB is not available in Pakistan at this time. But I think we talked about it earlier, Salim, I think when you were visiting, non-HDL cholesterol. I think that is a very good cheap alternative of ApoB, and I think that's what we should be focusing on and try to, put that more in practice rather than the LDL as we're doing now.
Yeah, no, I agree with you. My PhD was on non-HDL cholesterol. I think one of the comments that we had, I made that comment that non-HDL cholesterol has more than 90% correlation with ApoB. And I think there is a debate that when non-HDL cholesterol and ApoB have discordance, which is actually a very small proportion of the population, whether risk tracks better with ApoB or non-HDL cholesterol, that's a debate that I don't think we should get into today. But generally speaking, non-HDL cholesterol is what we call poor man's ApoB. And that really is what we should be using now in Southeast Asia and perhaps everywhere. It has been part of the guidelines here in US as well for a very, very long time.
Samir, you have a question?
I just wanted to say a comment. I'm hearing all of you speak, and it's kind of echoing very well with me, because I think the practice patterns that we have in Pakistan and Bangladesh are very similar to what we have in India, where majority of the healthcare is provided by the private sector, and the government sector does play a role, but a comparatively a smaller role. One thing is the mentality also, which I find very different between Southeast Asia, or I would say India, and compared to my time in the US. In the US, there was this concept of work-life balance, right? People would say, it's 5 o'clock, I'm going home, I'm going to go work out. It's a weekend, I want to go hiking, I want to guide my bicycle. That concept is very nascent in India. Even when you go for a walk and you see people, say, my patients, I ask them, do you exercise? Do you walk? And the answer is yes. I go every morning and I do my yoga and I do my morning walk. And then you ask them, do you sweat when you walk? And 90% of the times the answer is no, I don't sweat. So, the question is, are they actually taking their heart rate to the target rate where they get cardiovascular benefit, or they're just walking for the sake of walking? What is the physical activity that they're doing? Is it actually effective physical activity? That's just one thing which has always been bothering me. And also to the next point of, we're talking about LP cholesterol, a lot of cholesterol and lipidology. What about polygenic risk score? I know that that's not really panned out. What is the role of genetics? I know that multiple companies have been sprouting up in and around India, where they're doing genetic testings and 23 and more is big in the US, and there are similar companies in India where you get I got a blood test done also. I said, let me see what my risk score is. And, this entire thing came out and I had no idea what it meant. And the counselor who was there on the other side was also equally ignorant. So I didn't really put too much effort into trying to educate myself. But these polygenic risk scores, what is the role of that in your opinion? Can we study that a little bit? Just wanted your thoughts.
I can take that polygenic risk score. So, I mean, there is association. I think the question is, you take polygenic risk scores, you take traditional risk factors, all of that then comes to subclinical athero. And I think that's what Khurram would probably argue. We have something that should be coming out looking at what is the utility of polygenic risk score in somebody with zero calcium? I mean, the answer is generally pretty low. I think the only area where there is utility that we should not throw the baby with the bathwater is that polygenic risk score can be assessed very early on in life, right? Subclinical athero takes time to develop. So if you have very high risk families, you could use polygenic risk score early on to work on lifestyle and perhaps treatments as well. So I think that's where utility is. But I do believe that once you turn 30 and 40, then markers of subclinical athero generally are a risk multiplier that gives you an idea of a summation of every kind of risk you may have. But early on in life, I do believe that in those who are 10, 15, 20, 25-year-olds, I think there is perhaps some utility for polygenic risk scores, especially in the South Asian context.
So I agree with Salim. I think so. Genetics is your first risk factor. So that's fantastic. No other risk factor you can do at age 10 or 15, and you can truly make significant lifestyle intervention, which has shown to curb the future trajectory. Once you get above 35, 40, of course, if the decision is what's your true risk, genetics is like any other risk factors. It will track, but there is going to be disparities. So to guide management, subclinical athero may be a better one, but I'm a big fan of polygenic risk score. I think so early on interventions in their teens and 20s is the right time to get it.
And the other issue we have is that the polygenic risk scores right now are very much geared towards Caucasian populations. We really don't have any polygenic risk scores in South Asian. So we're hopeful that, with these large data sets, we'll have a little bit more information on that as well.
Yeah. I mean, that's one thing that we've been talking about in our hospital registry, that, should we take, when you're doing 2,500, 3,000 PCIs, plus sending so many patients to bypass, how about we just do, 100 patients of these or 200 patients of these and see which of the markers came up. There is a PhD who's wanting to tie up with this. This is something that we've been debating with. But the practice patterns are also very different, because here we are talking about affordability, that that 3,000 rupees is very expensive for someone to get a CT angio. And on the flip side, Dr. Kazmi, there are this whole group of people who are kind of affordable people, and they come to you and they say, Doc, I just do every test under the sun. My friend had a heart attack. We all have those patients, those family members. Somebody in my network, he was 27 and he dropped dead. Just do every test under the sun. And you're left scratching your head. Should I do a CT angio? And then they come 2 years later again. My CT angio showed 25% blockage last time. Do I need to repeat it? It's a complete treatment dilemma, breaking every guideline there is.
All right, guys, just for the sake of time, we'll take the last comment from Asha Kadir. If there is a burning question, Dr. Kazmi, you can also ask. Again, we are over 2 hours now.
Yeah, I was just say, I mean, I think the key here is obviously what Salim had said. I mean, there's a difference between population-based approach and individualized approach, and that's what has to be done. But I wanted to put a question to Salim. I mean, there was a paper from Pure, again from Salim, I think, talking about urban arm and the rural arm. And in the rural arm, there was higher risk with intake of refined carbohydrate rather than fat intake in the diet. What is your take on that?
Look, I know we have a lot of debate around Pure as well, how reliable the food diaries that were used were. I think one thing is for sure that refined carbohydrates, very high quantities, are not good one way or the other. That may be the best fuel source we have because it's cheap. But I think we have to take it with the totality of the data. And the totality of data is that, when you have very high levels of especially saturated fats, that's not a good thing either. So as much as we can move from saturated fat to polyunsaturated fats and keep carbohydrates under check and balances that we're not going above 50-55% of the total calorie intake, it's probably a balanced approach. I think balance is the key here, not going one way or the other, because then cost becomes a major issue as well, especially for the kinds of patients we're talking about today.
All right, last comment or question from Asha, and we will
Thank
conclude.
you. Thank you for putting this together, Sohail, and setting the momentum really, because I think as we've discussed, the incentive for prevention is so little in South Asia, because as Samir said, I echo that sentiment that the vast majority of the practice is private practice based, and even among us, where in Bangladesh, there isn't a separate IC fellowship, so to speak, unless you pursue it. So the vast majority of us don't go into imaging, irrespective of what it is. We just go into intervention because that's where all the incentives lie. So I think it's really time to, side by side, along with research, incentivize the prevention aspect of it, because we're seeing so much more of young MIs and so much more of lethal mortality-inducing MIs that we should focus a lot more on prevention, even if we're interventional cardiologists. And that's just really the take-home message that I took. And I learned a great deal from all the talks today as well. So thank you.
All right, with that, we will conclude today. Thank you so much for all the panelists and the attendees. This is something we should do more often, and we will definitely come back in a couple of weeks. This will be recorded. It will be shared. So again, thank you so much for all the panelists for your time, and hope to see you again. Thank you.
Well, we are just one last thing. We are planning another primary, the preventive symposium with Khurram and Salim. I think either July or September. So we'll work together and have all these people, and probably that. I think we should be doing it more frequently. It was great. Thank you.
It's a good segue. Thank you, Sohail, for leading this. This has been fantastic. As you can see,
so Bashir, I gave ideas. We should
high.
do active cardiology. Yes, it is. And then Bashir, I gave idea that if we want to start like a preventive conference, we should do 1 year in Pakistan, 1 year in India, the other year in Bangladesh, and that's something we can rotate.
The only problem is the visa issues with India. it's become.
But Samir will figure something out for us. Right? Yes,
We'll figure something out. I'm sure Samir is here, so he'll help.
Samir, no pressure.
All right, guys. No pressure.
Thank you.
Samir.
Thank you, Sohail, for leading that.
Thank you,
so much.
And thank you.
Thanks, Sohail.
Thank you. Bye.
Thank you.